Welcome back. Let's move on and talk about the nutritional implications of cancer. And there's a few things we need to consider. We need to consider how the cancer will impact someone's nutrition status, and then conversely, how that nutrition status can affect the outcome of the cancer, how well they respond to treatment, their survival, that kind of thing. We also want to think about the effects of cancer therapy on nutrition, because it isn't just the cancer itself that can have an effect on nutrition status. Sometimes the treatment itself, chemotherapy, radiation, that kind of thing, that can affect someone's nutrition status as well. So as part of this discussion, I think it's really important to think about some of those factors that have an impact on nutrition status. So when we think about factors that could influence nutrition intake, we want to think about things like pain, xerostomia, which is dryness of mouth, mucositis or painful sores that might develop in the oral mucosa, as well as just loss of appetite, nausea, vomiting, GI issues, changes in taste, early satiety, just feeling really fatigued all the time. All of these things can influence someone's nutritional intake. And a lot of those can be side effects of cancer treatment. So when someone's going through chemotherapy, it's not at all uncommon for them to have nausea and vomiting and painful sores in the mouth and dry mouth and that kind of thing. So we have nutrition intake, but then we also have this cytokine response, okay, to the cancer itself. Things like TNF alpha, IL-1, IL-6, and this kind of sets off a cascade of events that leads to a catabolic state. So not only are we not eating as much, but then the body is catabolizing at a very rapid rate, and we're losing muscle mass, and metabolism of all the macronutrients is changing and increasing. And so all of this together we refer to as cachexia. All right, this idea of wasting, really, as a result of both the cytokines and the catabolism in cancer, as well as minimal nutritional intake. So this cachexia in turn can have effects on one's outcomes. So whether that person's going to respond well to treatment, it's going to have effects on quality of life, on healthcare costs, certainly functional status. So it's this kind of slippery slope that patients can very quickly start sliding down once the, cancer has progressed and once they initiate cancer treatment. It's also important to note that the nutrition effects of cancer and cancer treatment, it's going to depend sometimes on the site of the cancer. So for instance, if someone has cancer of the oral cavity, the pharynx, the esophagus, this is going to have a direct effect on food intake, and that's before any treatment has even started. And so just because of the cancer itself, someone might have hyposalivation, so maybe they're not producing as much saliva, which is creating dry mouth or xerostomia. They may have a tumor that is making it difficult to swallow, so we call that dysphagia. It may cause an obstruction, there may be mouth sores, and all of this can be due to the cancer itself and then exacerbated by the treatment. When cancer is in the stomach or the intestines, it can have an effect on GI symptoms for sure. Patients can feel very nauseated. Maybe they're vomiting, they might not be absorbing nutrients as well. Maybe the tumor is actually creating a bowel obstruction. The effects of pancreatic cancer, again, are going to be directly related to what the pancreas does. So we know that the pancreas secretes digestive enzymes. So with pancreatic cancer, we're not going to be secreting as many of those enzymes. That can lead to malabsorption. Also, we know that the pancreas secretes insulin and helps to regulate blood sugar. So with pancreatic cancer, we're getting reduced insulin secretions, so we have potentially hyperglycemia. And then when there's obstruction of the pancreatic and bile duct, that common duct where the pancreatic juices and bile flow together into the duodenum, we can end up with jaundice or a yellowing of the skin and the sclera of the eyes. This is just showing in picture form what pancreatic cancer might look like. You can see the tumor growing in the pancreas, how that can obstruct that common duct for the bile and the pancreatic juices, and then that can lead up to a buildup of bilirubin in the blood, and that's why we get the jaundice. You can see in the sclera of the eye that yellowing. The effects of kidney cancer are going to be directly related to what the kidneys do. So we're certainly going to have an effect on processing of wastes, since the kidney helps to filter a lot out of the urine and concentrate urine. We can also think of just obstruction of the ureters themselves. We might have trouble urinating, oliguria. So vitamin D metabolism, why might we have altered vitamin D metabolism? We want to think about how vitamin D is activated in the body. It actually has to undergo 2 hydroxylations to get to its active form, once in the liver and once in the kidney. And so with kidney cancer, we're not going to get that second hydroxylation, so we're not going to be able to get vitamin D into its fully active form. Why might we have anemia? That's listed here as well. It turns out that the kidneys help to make sure that the body has enough red blood cells by making a hormone called erythropoietin. This hormone actually tells the bone marrow to make more red blood cells. So with kidney cancer, we're going to have decreased levels of erythropoietin and therefore fewer red blood cells, anemia. And now finally, we'll talk about liver cancer. Again, think about what the organ does. That will help you lead to what are the consequences if we have cancer. All right, so the liver obviously does a whole lot, but let's just touch on a few of the highlights. So we know that the liver makes prothrombin. This is a really important component for the blood clotting process. So if we have impaired prothrombin synthesis, which we might have with liver cancer, we're going to have a reduced ability for the blood to clot. Reduced bile, so we know that the liver makes bile. It's then stored in the gallbladder, and then it is emptied or squirted, I guess, into the small intestine when there's fat present. So with reduced bile production from the liver, we could have fat malabsorption. The whole purpose of bile is to emulsify that fat in the small intestine, so we could have problems with that. We could have low albumin levels because the liver makes albumin, and this can lead to fluid shifts. One of the really important things that albumin does in the blood is it creates an osmotic pressure that keeps fluid inside the blood vessels. And so without adequate albumin, we get fluid leaking in to that interstitial space, and we can end up very, edematous, or we can have ascites. A lot of times the classic presentation with the patient with ascites, or that large fluid-filled abdomen, has to do with liver complications, whether it's liver cirrhosis, liver cancer, any sort of liver issue potentially could lead to ascites. Many metabolic abnormalities. The liver does so much in terms of macronutrient metabolism that we could end up with altered carb, protein, and fat metabolism with liver cancer.